Okay, folks, this is Dr. Tröten speaking. Today we do a big surgery and bone reconstruction in the upper jaw. And to enhance the bone healing, we will use the aPRF technique from Professor Sugery in Nice. And the first thing we have to do is we have to obtain about 120 milliliters of blood. So what we are looking for is now a nice vein where we insert the venflon. This is sometimes the most tricky part in the whole procedure. Okay, now we got the vein. We slowly proceed and we hope the vein doesn't flap open. And now we take the special ampoules, and you see the blood has to flow really fast. It has to flow really fast. If it doesn't flow fast, please take immediately another vein. Okay, once it is full, remove it, take the next one, and always check if it is really flowing fast. It might now seem to you that the blood is a little bit too reddish for venous blood, but since the patient is in general anesthesia, you have to keep in mind that the patient is highly oxygenated. So once you finish with the first 4 ampoules, you put them immediately into the centrifuge, because of course if we take 12 ampoules today, the problem would be that you have a agglutination of the blood, a coagulation of the blood, which then will prevent the formation of the aPRF. This technique was developed by Professor Sugery in Nice, and it enhances bone regeneration extremely. So, as you can see, we had to choose a different vein. This was a rolling vein, so there was no way to get into the vein, and we then changed over to this vein, and it was nicely. Now we have 12 ampoules, and at the end you just put the band-aid and you remove, and then you just press on it for about 1 minute. So this is now the aPRF device. It's fully pre-programmed. That means you just insert the tubes with the acquired blood, and then you just press start, stop. And since you have to do it fast, I will show you how the centrifuge looks inside once the centrifuge process is finished. Okay. So the task today will be to do apisectomies on the second premolar on the right side, a big cyst on the second incisor in the front here, and then the big cyst which you have seen in the CBCT scan on this side. But before we start, of course, we remove the partial prosthesis, and this we will put in disinfection solution. So, we are starting now with dealing with the cyst here apical of the first premolar. We do a vertical incision here, far outside the original cyst cavity. Because we also want to do a surface cleaning And since we are lacking here bone, we have to prolong the incision here, also to deal with the periodontal defect distal of the first premolar. Now we revealed the surgical site. You can see here the first premolar, and right here you can see the granulation tissue of the periodontal defect that is reaching down to the apex. And since we want to save this tooth entirely, we'll have to clean this and also augment this with aPRF. Now the first step will be to do the opening of the apical cyst with the bone saw from Piezotome-2 lead. Now the writing is the other way around, and we start now. You can work without force, just touching the bone. And since you see this is real time, you also know how fast the new generation of ultrasonic surgical tools is. Okay. Now we just lift the buccal bone plate. We did the osteotomy. And of course we don't waste this bone, we just keep it in saline solution for later repositioning. And now, please suck here. Here you can see now the cyst. We left a little bridge of bone here just to stabilize afterwards the soft tissues. So since this is possible to work extremely precise with the piezotome, you can leave small bridges like this to support the soft tissues. Now we keep this piece of bone in saline solution mixed with chlorhexidine to obtain a disinfection and decontamination of the bone plate. Now we revealed the apex of the root, and since the cyst is adhering to the apex, we immediately start to do the apisectomy. For this we also use PS1 bone saw. And once again you can see in real time how fast the new generation of piezotomes cut even dentin. So now the apex is cut. You can see here now the specimen. You see there is no fracture of the root, so we can proceed. This is the apex. Okay. And now we start with the enucleation of the cyst, which we do traditionally with a curette. And of course, we also have to take care about the eruption of the cyst here distally. Okay, now we cleaned the cyst tissue, we enucleated the cyst, here from the main cavity, but we remove it to the distal periodontal defect. In the next step, we take the small diamond coated ball tip from the crown lengthening set, which is very nice and very fast when you do retrograde preparation on apices with a wider diameter. And you can see the surgical site, you see almost no bleeding, which is due to the minimal invasivity of Piezotome-surgery. And now we switched into mode D3 to do the retrograde preparation. And just by the sound you can hear that we are working in a different mode than when we are using the bone saw. So this is the side now after preparation. Unfortunately, in this position you're not able to see the prepared apex, but I will demonstrate this to you once we move over to the second right incisor. But once again you can see nice clean cavity, very minimal invasive procedure, precise cuts to the ultimate level. In the next step we just prepared the IRM cement for retrograde filling. We do a first disinfection with hydrogen peroxide 3% and not the strength of the hydrogen peroxide beam is important, but the duration. So you have to do it slowly to give the hydrogen peroxide a chance to fulfill its mission. In the next step, we are using chlorhexidine 0.3% for another step in disinfection. And of course for cleaning the site. And now we prepared the IRM, which we will now place retrograde into the apex. And we condense it well into the cavity that was prepared with the diamond-coated ball tip from the crown lengthening tip set for Piezotome-2. It took some minutes until the IRM cement hardened, and now we take the SL1 tip from the sinus lift tip set for Piezotome-2, and we use the diamond-coated flanks of this tip to remove the surplus of the cement. Once again, we do this in mode D3. And only with very, very slow movements, we are removing the cement. And once again, it is pretty fast and gives a perfect surface to the newly formed apex. And also with this tip, we can already start to remove adjacent contaminated bone. You can see here. So that means you can use this tip also as some kind of scraper. And as you have seen before, we were using a simple curette, but with a simple curette it's not possible to remove the infected layer of the bone, the contaminated layer. where all the inflammatory cells are that might prevent bone regeneration. You can still see how much we can remove here. We also clean in the distal bucket. But of course, we do this in mode D3 because we want to very carefully and little invasive clean the bone. And now you can see how perfectly clean the bone gets. You can see all the small vessels emanating from the bone. And of course we need these vessels bleeding slightly, because only bone regenerates bone. What we are going to place now, the aPRF, just enhances the bone regeneration. So when you have to clean small gaps, then of course you move back to the crown lengthening tip with the diamond coated ball to approach to very narrow spaces. And as you can see also with this one, there's a pretty amount of granulation tissue that you can carefully remove. Here you can see the granulation tissue. Of course microscopic. But with highest precision. This wouldn't be possible to do with curettes or with periodontal curettes. And at the same time, you're also doing some kind of root planing, decontaminating the apex and the surface of the root. You can see this is the last part of the granulation tissue which was palatal of the root. We also removed this. Now we have an absolutely clean site. You see healthy bone and almost no bleeding. Just enough to be sure that you're dealing with vital bone. Okay. In the next step, we are going to prepare the PRF. We did the centrifuge before. We keep this in this tray. Then we simply get in with the forceps, like this. And the adhering blood clot is just cut away like this. Then we move over to a sterile gauze, remove the blood clot, and place the aPRF in the tray. Always take care that really all blood cells, red blood cells, are removed. This we proceed with the next one. We just take the forceps, we get in, we grab the PRF, and sometimes you can see the blood clot is already separated. Then we just have to move over here, remove the blood cells, and place it back into the tray provided by the system. Always be careful, don't make too much a mess. All the mess you do, you have to clean afterwards. So if the blood clot adheres, you just cut it off with the scissor provided with the system. You place it here and you just stripe it off gently. With 12 ampoules, so we can put this away and Now we can see what we have produced. Now, as you can see, we prepared 12 aPRF membranes, clots. We sort them over this special tray. And to make really nice suturable membranes, we just put this plate on top and we leave it like this without pressure. For mixing with bone graft, we just take one of the bigger ones here because we will need a lot of bone graft. We put it in here and then we start to cut it according to Joseph Shukron's rules like this. You see, it's a pretty fast procedure. You just cut it into small pieces like this, like at the hairdresser. Don't do it this way, always do it this way, you're much faster then. Then of course you have to pour away the liquid that still contains some erythrocytes. This we can pour down here, okay? And this is then the pure aPRF that then will be mixed with bone graft. We put this back. We can do a mixing of about 50% bone graft. In this case, we take CalciOss. It's from a Japanese Swiss company, CalciOss Classic. It's pure beta-tricalcium phosphate. And we just pour it in. And according to the advice of Professor Shukron, we are also utilizing a small amount of metronidazole to the mixture. It's just for preventing a contamination. This is an advice by Professor Shukron, and of course we have to follow our teachers. Now we have the pure substance, and now we are gonna apply this to the site. Now we are back on our surgical site. We do a last rinsing with chlorhexidine. We also do a last check if we're dealing now only with solid bone, which is true. You can hear it from the nice sound. No granulation tissue left. And now we are going to insert the bone graft mixed with aPRF plus metronidazole. We just do it carefully without pressure because the bone graft material which we use now, which is CalciOss, it's just a placeholder for bone regeneration. The biological active parts are the aPRF, the periosteum, and the osteoblasts delivered by the endosteum from the trabecular bone network. Now we are placing the aPRF membrane on top of the defect. We wrap it around to the palatal side, fully covering the distal periodontal defect, and we just slide it under the palatal tissues. And since this is a relatively small opening, one membrane in this case will be sufficient because, as you can see here, we didn't destroy the periosteum, and the periosteum gives the bone regeneration feature. This is the situation now after wound closure. We took 6 ovicilium sutures, adapted the papilla here, a circumferential suture, really to have it tight. Here you see the aPRF membrane gaping out a little bit to really attach to the surface of the clean root. And here the distal suture. And now we will move on to the big cyst here on the second incisor in the front. In the next step we are moving over to the second incisor here. Once again we do incision here far outside the original area of interest. Then with the scalpel we can already remove the inner layer of the inflammation tissue. And we go here. Of course, if this would be a case with perfect crown margins, we would have to choose a different approach. But in this case, it's more important to have a full cover of the site. And for cosmetics, we can lose our thoughts maybe a little bit later on. The incision always has to be over solid bone. Now we prepare the mucoperiosteal flap. You can see here the entire area is covered by granulation tissue. And with a normal purette we can already start to check the extent of the bone destruction here. And you can see this root has almost no attachment to bone anymore, which we already have seen in the CAT scan. Now we were roughly removing the rough part of the granulation tissue just with the curette. And as you can see, there is no contact to the bone anymore. So we will do first a very radical apisectomy. Actually, we're going to remove the entire root, and then we will build up the bone here for later implant insertion. And to check to which extent we have to remove the apex, we start now with cutting at half length of the root to check whether there is a bone attachment on the palatal side of the root. But you see it's extremely fast cutting here. It just takes about 10 to 15 seconds to cut the root entirely. Okay. Now we luxate the apex, and now you will be able also to see what happened here. You can see here a slight longitudinal fissure in the root that goes right down to the apex, and of course we have here some foreign body material, which we are also able to see in the, here you can see the foreign body material, here it is. That maybe was the main cause for the cyst to build up, but at the end it combined with the periodontal disease. And once again you can see here there is a slight fissure in the root. You can also follow this. I'll try to demonstrate this. Okay, saugen. Können wir mal an der Oberfläche sein. Yeah, you can see here the fissure in the root. It's almost down to the apex. This is a big cyst cavity. We are going to use the bone scraper from the BS Fit Kit, once again in mode D3. And just as if you would collect autologous bone, you just scrape around the infected bone wall. Okay, and you can see here the main cyst tissue is already removed. Then we proceed with the cleaning process. We also remove the contaminated bone adjacent to the cyst cavity. You see how easy and without any force you can clean the area. You always have a perfect view on the side. And without any pressure, you just remove all the adjacent granulation tissue. Okay, you can see how nicely it removed. Since we found out that also the connection on the palatal side of the root is completely lost, we really have to do a very radical apisectomy now. We just leave the coronal part in order to support the soft tissues. Okay, you can see this is all covered with granulation tissue. And of course this will also have to clean away. So we go back to the bone scraper tip, switch back from mode D1 in mode D3 and remove the granulation tissue. The cleaning up process proceeds. You can see now we removed all the granulation tissue from the palatal side. And now we achieve a clean cavity and also remove the inflamed layer of the bone. Now you can see the cavity fully cleaned. We are taking now the TKW3 kit for cleaning the surface of the adjacent tooth, which is also root treated. And as you can see, the surface is fully blackened, and this is the result of corrosion processes and the transport of the corrosive products to the surface of the root. But the bone is very solid on top, so of course we have to keep this tooth for the time being. Once again, after the perfect cleanup, you can see fully vital bone and only very, very little bleeding because ultrasonic surgery is really minimal invasive. We once again gonna place some bone grafting here, which of course was already prepared before, and it is still mixed with the aPRF. We're gonna place it here. And once again we place an aPRF membrane on top of the site to enhance bone regeneration. And in this case, of course, we have to take care about the regeneration of the soft tissues too. So we are going to put it in a double layer
and place it around the neck of this second incisor and leave it out a little bit. So the first suture is once again a circumferential suture. You can see here the aPRF membrane gating out. Okay, now the work on the right side is finished. We did the apisectomy with retrograde filling here on the first premolar. We did the cyst enucleation and bone build-up here in the second incisor region, and now we move to the giant cyst on the left side.